everyone. Once again, I would like to thank the PPS Norlu for inviting me to talk on a topic that has become a global health problem, even more so complicating at present the management of people who are obese and infected with COVID-19. This lecture actually is not included in the PMAM manual. Baka po kasi hahanapin ninyo. But since obesity is another form of malnutrition, we have decided to include it in the series. Okay. Worldwide, obesity has nearly tripled since 1975. In 2016, there are more than 1.9 billion adults who were overweight, 650 million adults were obese, and 340 million children and adolescents aged 5 to 19 were overweight and obese. In 2019, about 38.2 million children under the age of 5 years were overweight or obese, and almost half of these children under 5 years who were obese are found in Asia. If these trends continue, by 2022, more children and adolescents will be obese and overweight. Many low to middle income countries are now facing the double burden of malnutrition, which is the coexistence of undernutrition along with overweight and obesity. While these countries continue to deal with problems of infectious diseases, especially now with the COVID-19, there also is a rapid upsurge of diet-related non-communicable diseases. This double burden of malnutrition occurs within individuals, households, and populations, and may continue throughout life. This double burden of malnutrition is also a global challenge. So what are the causes of obesity? The fundamental cause of obesity and overweight is an energy imbalance between calories consumed and calories expended. You can see here the result of environmental and societal changes, and these are seen globally. Like food advertising aimed at children. Ang galing ng mga McDo and Jollibee, all with their mga free toys, di ba? And then large portion sizes, super size me, upsize ang mga drinks, overconsumption of sugar-sweetened beverages. There are also declines in overall physical activity both before and after school hours. Dati, before the pandemic pa, there are decreased physical education and recess time at school. Increased frequency of eating away from school. Community environments that inhibit active living, especially now during the pandemic. Lahat tayo we are on quarantine, karamihan naman na quarantine. There increased screen time, walang activity ngayong pandemic. There increased availability of low-cost, high-calorie, refined grains and added sugar. Why does childhood overweight and obesity matter? It is because childhood obesity is associated with a higher chance of premature death and disability in adulthood. Overweight and obese children are more likely to stay obese into adulthood and to develop non-communicable diseases like diabetes and cardiovascular disease at a younger age. These are the percentage of obese children who become obese adults. 30% of preschool children, 50% of school-age children, and 80% of adolescents continue to be obese adults. Childhood obesity consequences. Obese and overweight children suffer from short-term and long-term health consequences, like metabolic syndrome. This is the clustering of metabolic risk factors for type 2 diabetes and atherosclerotic cardiovascular diseases in adults, such as abdominal obesity, hyperglycemia, dyslipidemia, and hypertension. Metabolic syndrome actually is the #1 risk factor for the development of type 2 diabetes and cardiovascular diseases. Gastrointestinal consequences such as your non-alcoholic fatty liver disease, cholelithiasis, and your GERD. For orthopedic, slip capital femoral epiphysis, which presents as dull pain on hips and on the groin. Your Blount's disease or the bowing of legs presenting as knee pain in obese children. Fractures, asthma, obstructive sleep apnea. For neurologic, the idiopathic intracranial hypertension or your pseudotumor cerebri, this typically presents with headache. some nutritional deficiencies such as vitamin D and iron deficiency, and psychosocial, the presence of poor quality of life due to decreased physical, social, emotional, and school functioning. There are also social exclusion and peer relationships, which these children are targets of discrimination and bullying. The following are the factors affecting weight, and this should also be noted during our initial assessment of children who are overweight and obese. Prenatal, as Dr. Silvestre has mentioned, on the first 1,000 days, prenatal, natal, infancy, and childhood, the practices, they can affect future weight in children. For example, maternal caloric intake, maternal obesity with or without diabetes, and maternal smoking increases the risk of obesity in the offspring. Natal, although birth weight is a poor predictor of future obesity, infants who are premature or small are at higher risk of developing abdominal obesity and other comorbidities associated with obesity later in life. Infancy, breastfeeding when compared to formula feeding is associated with a lower risk of overweight. As an example, feeding infants solely with breast milk during the first 3 or more months of life reduces the risk of overweight in childhood. The longer the duration of breastfeeding, the greater the reduction of risk of obesity. Childhood, unhealthy feeding practices, and the lack of exercise. And for family history, for both obese and non-obese children less than 10 years of age, having an obese parent more than increases the risk of obesity. Environmental and societal changes. Almost all obesity in children are strongly influenced by environmental factors caused by either a caloric intake that is greater than needs and a sedentary lifestyle. Psychological and social issues such as emotional stress, for which overeating is sometimes used as a coping mechanism. Obesity is also associated with shortened and irregular sleep. Medications, a number of drugs can cause weight gain, including certain psychoactive drugs, your olanzapine, risperidone, and anti-epileptic drugs, and your glucocorticoids. Syndromic obesity. A variety of specific syndromes in which obesity is a primary manifestation have been identified, such as your Down syndrome, the Prader-Willi, Bardet-Biedl syndrome. These are rare causes of obesity. Endocrine causes of weight gain are identified in less than 1% of children and adolescents with obesity. Endocrine causes such as hypothyroidism, Cushing syndrome, and hypothalamic obesity. Weight assessment is accomplished by getting the body mass index. BMI is a simple index of weight for height that is commonly used to classify overweight and obesity. It is defined as a person's weight in kilograms divided by the square of his height in meters squared. The square of his height in meters. So this is the BMI for adults. So when do we say a person is overweight and obese? For WHO, it is at a BMI of 25 to 29.9. But for the Asia Pacific or the Philippine Association for the Study of Overweight and Obesity, they have a lower cutoff. Why lower cutoff ang Asians? Asians has lower cutoff of BMI because it has been found out that there is a high prevalence of type 2 diabetes and cardiovascular risk factors even with a BMI lower than 25 dito sa may WHO cutoff natin. Kung titingnan nyo ang normal weight from the WHO, 18.5 to 24.9. Even with a 24.9, marami sa Asians po nakikitaan na may mga risk factors for diabetes and cardiovascular diseases, which is why some studies lowered it down to 22.9 yung cutoff. BMI has its drawback. if you're very muscular or have a large frame, your BMI calculation may show you as overweight or obese even when you are not, as seen in this picture. The other one is obese, while the other one a bodybuilder, but both have the same BMI of 33.9. Yun po ang advantage ng ating BMI. So for BMI for children, 2 years old and above, since children grow in height as well as in weight, the norms of BMI in children vary with age and sex. So BMI interpretation is different in children. We use the WHO or the CDC growth charts. So here, the CDC, the normal weight under the CDC is from the 5th to less than 85th percentile, while that from the WHO growth charts, it is -2 standard deviation to less than 1 standard deviation. And here also is for overweight and obese definition for children. This is the BMI for girls, color-coded ng ating BMI. These are downloadables you can get and then you can print and you can use them sa mga clinics natin. For CDC, on the right side, on your right, makikita nyo dito at 2 years. So you can use this for those 2 years. Kasi dito sa WHO at nag-start siya at 5 years. This is the BMI for boys. We have an example here. A 9-year-old and 3-month-old boy who weighs 40 kilograms and stands at 135 centimeters have a calculated BMI of 22. Pag adult ang BMI na 22 ay normal. But when you plot this sa growth chart ng bata, nasa obese side na po siya. So, always remember that BMI interpretation is different in children. Otherwise, nalilabel natin sila ng mali. Baka nagiging normal. Okay. Oh, sorry. So for every child follow-up, let us make it a point to always plot the weight, the length, and the BMI. This is a very good trend of BMI, from being obese at 9 years old to normal weight at 15. Kung hindi siya nag-weight loss, the weight may have been maintained while the child's height is going up, tumatangkad. This is a very nice trend. Pag BMI, this is a very nice trend. Pero pag ito ay height trend, hindi siya maganda. Ibig sabihin, hindi siya tumatangkad. This is what we use for children 0 to 2 years old, the weight for length. We have here another example, 11-month-old male infant who weighs 10 kilograms and 75 centimeters. So you plot it. So ang plot niya, nasa normal siya. So this is what we use for 0 to 2 years old. Okay, other methods of assessing obesity, aside from the BMI. You have here your dual X-ray absorptiometry or the DEXA scan. This is a reliable and accurate measurement for fat mass. It has been validated in children and adults and considered as the standard for measurement of fat mass. However, DEXA and other imaging techniques cannot be used for mass screening or in everyday clinical practice. Another method is this skin fold thickness. This estimates the percentage of body fat by measuring skin fold thickness at specific locations on the body. It uses skin fold calipers, and usually ito apat na ito ang mine-measure: the triceps, biceps, suprailiac, and the supraclavicular. So other methods of assessing obesity, we have here your waist circumference for denoting central and abdominal obesity. For Asian, the cutoff for men and women is more than 90 for men and more than 80 for women. Children has no established cutoff points. Waist to hip ratio, still for abdominal obesity, the cutoff point as follows. And also, there are no established cutoff points for children. Waist to height ratio, still for abdominal obesity, the cutoff value is 0.5. An advantage of this waist to height ratio is the simplicity of the health message to keep your waistline half your height. It allows the same boundary value of 0.5 for men, women, and children from different ethnic groups. So pwede itong gamitin ng mga bata, the waist to height ratio. Why does waist size matters? because abdominal obesity has been found out to have increased risk for type 2 diabetes and cardiovascular disease. So how do we measure? We have two measurements for waist circumference from the WHO and from NIH. For WHO and the IDF, measure the waist circumference midway between the highest point of the iliac crest at the bottom of the rib cage, dito banda. And for the NIH is above the superior iliac crest. Yan po ang ano ng waist circumference nila. And for the hip circumference, we measure around the widest portion of the buttock. Obesity as a disease. In June 2012, the American Medical Association declared obesity a disease. Children, like adults, suffer from the manifestation of obesity on most aspects of their physical and psychological health. Adiposopathy is a term used to describe the endocrine and immune response to increased adipose tissue, while the fat mass disease describes the physical response to increased adipose tissue. So the comorbidities are as follows, you can see there. In addition, psychological issues arise as a result of obesity and affect the quality of life. So the quality of life of children with obesity may be poor. They are at increased risk of isolation from peers. They are subject to bullying. They lack social and age-appropriate relationships, anxiety, binge eating, night eating disorders, and bulimia. Clinical evaluation of child with obesity includes a focused review of system and physical examination. The more common are shown here with the related comorbidities. For example, nervousness, school avoidance, and social inhibitions, the related comorbidities, depression and anxiety, and bullying. For presence of fatigue and muscle aches, probability of a vitamin D deficiency. Polyuria, polydipsia, nocturia, fatigue, with the presence of acanthosis nigricans. We can, maybe the patient has type 2 diabetes. Headache and facial numbness. The patient is hypertensive with papille edema. This can be a pseudotumor cerebri. Decreased linear growth. In the presence of decreased linear growth and goiter, we suspect hypothyroidism. Decreased linear growth with violaceous striae, buffalo hump, and moon phases, Cushing syndrome is entertained. And as follows, yung ating mga related comorbidities. So we also have obesity-associated genetic syndromes, and also children of special needs like the spina bifida. So they have associated weight gain. So in genetic causes of obesity, you should consider children with severe obesity before the age of 5. These young children may present with developmental delay, short stature, dysmorphic facies, or hyperphagia. This is a picture of acanthosis nigricans, wherein the hyperpigmented velvety plaques in body folds of obese person in the neck, axilla, elbows, knees, knuckles, and lips. This is caused by hyperinsulinemia, which stimulates the formation of acanthosis. Acanthosis nigricans also predicts the future development of diabetes. So what to do next when a child comes to you after the initial assessment? Appropriate labs and studies are considered according to age and BMI. For non-fasting lipid profile should be checked in children 9 to 11 years old who are healthy or within normal weight, and another should be taken at 18 to 21 years old. For overweight children, after screening for medical risk, do the lipid panel. If no risk, but if they have risk like family history of obesity, type 2 diabetes, hypertension, dyslipidemia, acanthosis nigricans, you do also FBS, ALT every 2 years if the child is 10 years old. For obese children, after screening for metabolic risk and assessing the age, a fasting lipid profile should be done. In addition to your glucose, ALT, AST, should be done every 2 years if the child is more than 10 years old. We also have other laboratory evaluation. Children with obesity presenting with deceleration of growth, symptoms of hypo or hyperthyroidism, Cushing syndrome, obstructive sleep apnea, those with abdominal pain, irregular menses, headache, we can do these laboratory tests such as thyroid function test for hypothyroidism, plasma cortisol or your 24-hour urine cortisol for Cushing syndrome, sleep study for obstructive sleep apnea, the liver or gallbladder ultrasound for non-alcoholic fatty liver disease. Ovarian ultrasound for PCOS, brain imaging if you suspect hypothalamic obesity, vitamin D levels for vitamin D deficiency. For genetic obesity, we can request for karyotyping and x-rays for Blount's disease and or your sleep capital femoral epiphysis. Weight is typically the goal that most patients and parents focus on the most. This is not necessarily the goal that should be focused on. Young children have the potential for growth so that their BMI will improve with weight maintenance as they continue to grow. Therefore, the first weight goal for everyone should be weight maintenance. So for 2 to 7 years of age, 2 to 7 years of age who are overweight, we recommend weight maintenance only. But when they are overweight, but with no complications, still we do weight maintenance. But if complications set in, weight loss is already recommended. For 7 years old and above, overweight with no complication, we still recommend weight maintenance. But if with complications and they are obese, weight loss is already recommended. So for the general treatment goals, behavioral goals, promoting lifelong healthy eating and activity behaviors. And for medical goals, this is to prevent complications of obesity in childhood and adulthood. And of course, to improve or resolve existing complications of obesity. This is the management of an infant with obesity for age 0 to 24 months. For behavior and sleep, no screen time, no TV in the bedroom. Allow the infant to feed themselves and do not force them if they indicate refusal. And they should be having sleep for 12 to 18 hours. For the intake, exclusive breastfeeding for 6 to 12 months, appropriate formula feeding ingestion for age. Ideally, delay complementary foods until 6 months. There should be no juice, sugar-sweetened beverages, no fast food, and no desserts. For the activity, keep them active in the playpen or on the floor. Encourage direct interaction with parents as much as possible. And of course, no media should be given to these children. For children 5 to 9 years old, intake 3 meals with 1 to 2 snacks in a day. Desserts should only be given on special occasion. Still no sugar-sweetened beverages, no fast food, age-appropriate portion sizes. Praise them for trying new foods and consider a reduced carbohydrate diet. For the activity, they should do moderate to vigorous activity for 60 minutes or greater each day. This can be organized or not. For behavior and sleep, the screen time limit to 1 to 2 hours. They should have routine sleep pattern. Still no TV in the bedroom, and they should be sleeping at about 11 to 14 hours. All meals should be at the table, and parents should be role models. They should not also be over-controlling. Sleep study if severe obesity and or symptoms are present. Tonsillectomy and adenoidectomy is if indicated. Pharmacology, minimize obesogenic medications such as antipsychotics, such as glucocorticoids. Treat asthma with controller meds to minimize systemic steroid use. And consider your ACE inhibitors for persistent hypertension. Okay, activity recommendations for 5 to 12 years old. Children should accumulate at least 60 minutes or up to several hours of age-appropriate physical activity on all or most days of the week. This daily accumulation should include a moderate and vigorous physical activity, with the majority of the time being spent in activity that is intermittent in nature. Children should participate in several bouts of physical activity lasting 15 minutes or more each day. Children should also participate in a variety of age-appropriate physical activities designed to achieve optimal health, wellness, fitness, and performance benefits. So here are examples of activities that can be done, especially now, the pandemic. For aerobic or endurance, you can do running, jumping, bone building such as hopping, jumping, and running, push-ups, tree climbing, kung walang puno, stairs, use the stairs, go up and down the stairs, sit-ups, and active play like walking, dancing, and jump rope. In considering how to modify the food intake, there is no universally accepted approach. An understanding of appropriate intake for a normal weight child is necessary as a starting point. So this is the food pyramid from FNRI, which can guide us on how should one eat in one day. Maganda ito para ipakita sa mga mothers so that they can follow. This is the food pyramid. Another one na food guide is the Pinggang Pinoy. Pinggang Pinoy, this is a visual tool to guide Filipinos in consuming the right amount of food in every meal. It is of 5 population groups, namely for kids, teens, adults, elderly, and pregnant and lactating mothers. This is also downloadable. You can print them and you can show this in your clinic sa mga nagpa-follow up sa atin. You can give it to them. Or you can advise them to download it in the internet. So this is how it looks, the Pinggang Pinoy. And there's also an instruction on how to fill up your kids' plate. May age din dito, which you can follow for 3 to 5 years old, 6 to 9, and 10 to 12 years old. And we have also the sample one-day plan, which they can follow. So, pharmacology. The use of weight loss medication in children with obesity is limited. Orlistat is an FDA approved for children 12 years old and above, though the weight loss is small, and side effects preclude usage in most patients. This may cause oily stools which are not tolerated by children. Metformin, this is FDA approved for children with type 2 diabetes, age 10 years old above. Several studies have been made on its use on obesity, but due to the limited weight loss efficacy, it is not considered as a weight loss treatment. It is, however, useful for elevated serum insulin levels, and it also prolongs duration of time before the onset of type 2 diabetes. Metformin may also cause gastrointestinal upset, especially in the first few weeks. Another drug is the topiramate. This is not FDA approved for weight loss in children. It has been used for seizure control in children for years. This controls cravings. However, it can cause cleft palate in the fetus and may cause paresthesias of extremities, cognition disruption, such as confusion and difficulty concentrating. For phentermine, this is FDA approved for weight loss in children 16 years old pataas. This has been used in adolescents, although weight loss is small to moderate. This may cause anxiety, tremors, slightly increased blood pressure. So for the management of childhood obesity, prevention is still the key. This is a very good obesity infomercial na pwedeng ipakita natin sa clinic. Or remember the 5210, 5 fruits and vegetables each day, 2 hours or less of screen time, 1 hour or more of physical activity, and 0 sugary drinks or food. So in summary, obesity is a chronic disease which, when originating in childhood, can lead to medical and psychological complications and premature comorbidity and mortality. Identifying and classifying these children as early as possible is important, as is identifying comorbid conditions. Management of a child with obesity is not just to decrease their BMI, but of course to minimize their disease state and change their development of future complications. Again, prevention is still the key. These are my references, and thank you for listening.